All right, the purpose of this video is to walk you through our musculoskeletal health risk audit, which is designed to help employers see under the surface of what's going on. High cost claims, the surgical procedures that are showing up on claims, these do not tell the whole story, and we need a better data set to understand, well, how and why are these 2 to 3% of employees getting down to a musculoskeletal surgery or high cost claim each year, rather than installing like physical therapy to try to prevent the surgery and hope that people utilize the service. This gives us a snapshot of where are the problems are actually coming from, so that if we're going to choose a solution to integrate, where do we integrate to create the most bang for the buck on the service? So we carefully craft a survey that gives us all the information we need to develop a risk profile for each employee. And what this does is helps us better understand who's risky, who's not, where are the high cost claims coming from. And some of the first ways we start to break down who's risky is by age distribution. There are just certain things we know about things that happen in the body as people get older, especially if they're not doing the correct things to take care of themselves, that make somebody more risky. So let's talk about that real quick. You can see 38% right here are age 41 to 50. These people are getting into that phase of life where they will consider surgical procedures if things aren't going the way that they want them to. Certain types of wear and tears can show up here, but the real bucket that I want to look at is this next one down, this 32%, this age 51 to 65. These people are aging into joint replacements, and these are a very high cost profile. And so what we want to do is understand, like, okay, well, we've got a large bulk of population getting into the age where joint replacements are going to start coming into recommendation. What can we do to mitigate that? So the reality is joint replacements can be pushed way into the future. Most people just aren't receiving the right care at the right time or the right education to understand how to do that. And after thousands and thousands of reps, I can confidently say an MRI or an X-ray that looks really bad is not the deciding factor if somebody should have a joint replacement or not. I've seen a tremendous amount of people whose X-rays look really terrible, but they are able to get functional and pain-free and move really well and push that way into the future, even with an image that looks bad. Okay, so this all has to do with education and integrating with people at the right time. The best thing we can do for the joint replacement crowd is push that so far into the future that they have retired and are now on Medicare. It's more cost effective for the employee, it's more cost effective for the employer, and that brings up our little 6% bucket right here. These are people who are already of Medicare age. They're still working, they're still on the health plan, they still have high risk for joint replacement. But if we can get these people to retirement and onto Medicare before they have this high cost thing, it's better for them, it's better for the employer. And these are just things that we need to consider when we're looking at where are high cost claims coming from and how can we start to build a better solution around, okay, well, where should we integrate if we're going to prevent this problem in the future. And the next thing we look at is our pain location. Now, this is a pretty standard set. This is not industry specific. This is very specific for this manufacturing company. But if we look across the world of pain, low back is typically at the top and shoulders are number 2. Anything below that can kind of bounce around a bit. But main point to make here is 96% of the people have pain with lasting 6 months or longer. There's a very high amount of people with pain, and it's such a small amount of people showing up on the claims. So you just have to understand the claims downstream are coming from this 96% of people with pain, and how they manage that over the course of time is what lands them in that high risk, high cost claim bucket at some point in the future. When we look at high cost claims, probably 2 to 3% per year are going to have a musculoskeletal related surgery, and that's pretty consistent year over year. So the question isn't how can we prevent the high cost claims in that high risk surgical bucket. It's how can we back up into the moderate level of risk and solve the problem there so that the 3% becomes 2% and then 1% or 0.5%. The only way we're going to stop those surgical procedures is not by just providing therapy for people who have pain. It's looking further upstream to find the problem before it starts and integrate with them early enough so that we prevent them from making their way down there. And we'll see why people get there here in just a little bit. So a lot of low back pain here, a lot of shoulder pain. The other thing we can do with this pain location is we can craft our questions in a way where we can pair certain pain locations in the body in a high prevalence with certain work areas in the manufacturing plant. This could help us make an ergonomic play. It could also help us better understand how do we need to rehab this person more effectively so that their bodies are more resilient in that work environment, right? So next, we've got our risk distribution. This just gives us this highlight of how many people are high risk, moderate, and low risk. So a lot of low risk people, and that's great. But there's two things that this is really important for. One is understanding if you install a solution, the results in return you're going to get in 0 to 12 months are the high risk bucket. It's getting these people early, getting them in before they have a high cost claim who are already really risky, and just putting a stop sign on it, right? The next big bucket is how do we have long-term savings, 12 months and beyond. That's integrating with our moderate risk. There's a ton of these people, right? So the other thing it allows us to do is because we know who these individuals are, like point by point, is we can actually triage them into care. We can be proactive in engaging that person via phone, text, email, whatever the case may be, and sweep them into the solution so that we can start helping them solve their problem. And when they have a risk score, they automatically have a baseline care frequency based on how risky they are. So they're probably going to come in and be on a plan of care to solve the bulk of their problem up front. But once they're off their plan of care, moderate risk people are going to be seen once a quarter, no matter what. High risk people are going to be seen once a month, no matter what. We want to take their risk and start to reverse it backwards by seeing them more frequently and consistently, making sure they're staying plugged into the things they need to do so that they don't continue down the slippery slope to a high cost claim. We also break this down, no surprise here. Less of the executive crowd, still plenty of the salaried crowd. These are our desk guys. And then our hourly, who are typically the workforce, the labor force. They're typically the highest percentage of people with pain. It's just good info to have. Where's the pain coming from? This is a quick snapshot of how long people are dealing with their problems. The longer they deal with it, the closer they get to a high cost procedure. And this is, sometimes this can fluctuate. Sometimes the lower end, 6 months to 2 years has a lot of people. Sometimes people are 2 to 5 years plus, a big bulk of people there. But it just shows you with your particular employees, how many people have been dealing with something for a long time. And then finally, this comes to the head at our clinical snapshot, which is where we take all the things people have tried and kind of lump them into percentages. So of the 96% of people with pain, only 30% have tried physical therapy. So that means a lot of people have the problem and aren't doing anything. 21% have tried chiropractics. That's probably exclusively related to the low back pain. 12% have had an injection already. And that's not a very high number, but injections typically come in series. So one person probably getting multiple injections. And the cost profiles of the injections can be all over the place. But the thing to understand about injections, and then the 30% who have tried imaging next, right? So in this clinical snapshot, what we actually have is not a lot of people trying therapy, not a lot of people trying chiro, not a lot of people getting injections, not a lot of people getting imaging, although 30% is a pretty high number. What we actually have here is, especially with injections and imaging, is these are failed attempts at pain relief. And those are stepping stones to surgery. Somebody gets an injection that doesn't work, that is evidence that they need a surgical procedure to solve their pain. If somebody has an image, the imaging costs can be all over the place. I mean, these can be direct medical costs that show up in a big way on the claim sheet. But the bigger problem is that they are showing people that they are broken, and that's not true. Sometimes it's true. Sometimes surgery is necessary. We're not going to ignore that. But a lot of times it's avoidable and it's unnecessary, and we have lots of data to show that. So the point about these is that the numbers aren't just super high, but the decision-making environment that they create are what creates the bigger spending in the months or years to come, right? So 2% of this crowd has already had surgery, and that kind of follows suit to what we see year over year. And now we know where they're coming from. Now we know where people's risk is. And then we want to take each one of these and we have an expanded view. So like we take that 30%, we actually break down of that 30%, what are the direct medical costs? What are the soft costs with like productivity, loss, time away from work? And what we'll actually see is like of that 30%, probably less than 10% actually completed their plan of care on an off-site physical therapy. And then we see how can that change and be improved with an on-site or virtual access to therapy at no cost to the employee. Because a lot of times people fall off because there's a time gap they have to fill, there's a wage gap they have to fill, there's the cost, whether it be co-pays or meeting their deductible that they have to consider, and is across the board for all of these clinical snapshots. It's direct medical cost, soft medical cost, and what does that look like for the employee and for the employer. So it's a really detailed view of what are we actually looking at here. And it just gives the deepest level of insight into both direct costs, soft costs, consumer psychology, and how do those numbers play out when you have to go offsite to receive it versus on-site or some type of direct access to a solution. And so right now, we're actually doing this for employers. We're looking for a handful of employers to run this engagement at no cost to give them deeper insights into their MSK problem so that when they're making a choice on a solution, they can make it based on a complete view of the data, not the incomplete view of just, hey, we have a lot of claims, we need to do something, let's do physical therapy and hope people use it. We actually want to create real solutions for real problems that drive real results and return on investment for our employers. So keep an eye out for the next video, which is going to be a detailed breakdown of these expanded views so you can just kind of get a better idea of what those look like.